presence will definitely enhance the webinar value. At this special moment, I would like to welcome all attendees. We appreciate your willingness and enthusiasm to participate in this webinar. Thank you for giving me the opportunity to contribute to this webinar. I hope all of you will enjoy the session. Have a good time. Thank you.
Thank you, Jinsi ma'am. With great anticipation, we now look forward to the inaugural address from the visionary leader of our institution, Dr. Professor Jolly George, Principal, Sree Anjaneya College of Nursing. Your words have the power to ignite the flame of curiosity and inspire us to strive for greatness. With respect, let me welcome our Principal Ma'am for inaugural address.
Good morning to one and all. It gives me immense pleasure to welcome you all to this national level webinar on innovations and challenges in reproductive health and infertility management, organized by the Department of Obstetric and Gynecological Nursing, Sree Anjaneya College of Nursing. We are truly honored to host such a significant event that addresses one of the most pressing issues in modern reproductive health. In today's fast-paced world, infertility affects millions of couples and continues to be a deeply personal and social challenge. With the rapid advancements in medical science and technology, the field of infertility treatment is witnessing revolutionary progress, and it is vital for nursing professionals to stay abreast of this development. Today, we are privileged to have with us three distinguished resource persons, each a stalwart in their respective domains. Professor Dr. Sabida Naik from Nitte Usha Institute of Nursing Sciences, a revered academician and expert in women's health. Dr. Sushmita Ramona Karkada from Manipal College of Nursing, known for her pioneering work in reproductive and maternal health, and Dr. Aravind R, leading specialist at the ICRA Fertility Unit Calicut, whose clinical expertise in infertility treatment is widely recognized. We are deeply grateful to all three of you for accepting our invitation and for taking the time to share your invaluable knowledge with our participants. I also extend a warm welcome to all the faculty members, students, healthcare professionals, and delegates from across the country to have joined us for this event. Your participation is a testament to the importance of continued learning and collaboration in healthcare. Let us use this platform not only to gain insights into the latest treatment modalities, but also to ignite discussions, share experiences, and strengthen our commitment to compassionate, evidence-based reproductive care. Before I conclude, I would like to appreciate the Department of OBG Nursing for their initiative, dedication, and meticulous efforts in organizing this webinar. It is through such academic endeavors that we build bridges between education, research, and clinical excellence. With these words, I hereby declare the webinar inaugurated. Wishing you all a fruitful and enlightening session ahead. Thank you.
As we start this journey of knowledge and collaboration, it's my honor to introduce our esteemed resource person for this session. Today, we have the privilege of welcoming Professor Dr. Sabida Nayak, Vice Principal, Nitte Usha Institute of Nursing Science. She has completed BSc Nursing in 1992 from Mangalore University, MSc Nursing in 1998 from RGUHS Bangalore, PhD in Nursing in 2019 from Nitte Deemed University. She has in her credit more than 20 projects, and this is for UG, PG, and PhD scholars. She has published more than 30 papers in various national international journals and has also paper published in Scopus Indus and Web of Science journals. She has published a book on health informatics in 2023. She has in her credit Best Teacher Award in 2023 from NITE Deemed University. Let's welcome Professor Dr. Sabita Nayak. We eagerly await your presentation and look forward to gain new perspective from your expertise. Over to you, ma'am. Our speaker will be joining us soon. Please wait.
Due to some technical inconveniences, our speaker will be joining us soon. Please wait. Ma'am, we are not able to hear you, ma'am. Sorry for the delay.
Archana, hello, Archana, hello, Archana.
Ma'am, we are able to hear you, ma'am.
No, this is through the mobile. Can I
Yes,
go
ma'am.
to the mobile because the computers I'm not able to.
Ma'am, we are able to hear you, ma'am.
Yeah, this is through the mobile.
Yeah.
Huh? I just start with, okay, by then somebody is
Okay,
looking
ma'am.
into the computers. Is that okay?
Okay, ma'am. Okay.
Yeah. Good morning to all. Good morning. Hello.
Yes. Good
Hello.
morning, ma'am.
Yeah, good morning. I'm really thankful to the organizers for giving me an opportunity to be a part of this program. And I think we were supposed to be online, I mean offline, and but then because of weather conditions, I think it has been online. And I think I'm really sorry for the delay. That's because of this computer or technical issues. So now I'm with the, mobile, but then I'm Sabita Nayak from NITE, Usha Institute of Nursing Sciences, NITE deemed to be university. So my topic here is on modern reproductive health challenges, causes, and solutions in infertility. So when it comes to reproductive health, I think it's been really concern because these days we come across very many issues related to reproductive health. So let me just give an overview of what are some of the challenges and a few overview on infertility causes, the male and female causes. Next slide, please. Archana, next slide. Yeah, the agenda for today you can very well see. We will look into the modern era challenges, male infertility, the causes and solutions, female infertility, the causes and solutions, and the global and Indian scenario in brief, and the future outlook. So the next slide. Yeah. If you look into the WHO definition, all of us know what is health, right? Health is more of a complete physical, mental, spiritual, and it is not only the basis of infirmity or disease, what we say, but then when it comes to reproductive health, you can also see that it's also more or less a complete physical, mental, and social well-being, not just the absence of disease or dysfunction, but includes rights to safe reproduction, family planning, and health services. It also encompasses the emotional and social aspect of the reproduction. As we all of us know, when it comes to reproductive health, more or less, emotional, psychological impact is also there when it comes, especially when it comes to, infertility. More or less, emotional or psychological impact bears a brunt on the couple, and that is why it's very very essential that we look into these reproductive health as a major challenge, and then how women and or the couple themselves are able to modify their lifestyle and bring about the change in the reproductive health. So this is how it is defined by WHO, and we'll see further into the modern era challenges. Next slide, Archana. Yeah. So if you look into the importance of reproductive health, you can very well see it is crucial for population health and growth. I think today's uh, citizens, they are the future generations because young citizens of India are the future, who look into the development of the country. So it's crucial for population health and growth when we say it all falls or it all takes away from the reproductive health. So very important is for the population health and growth, the reproductive health of the people is also very essential. May it be a male or a female, when it comes to reproductive health, and if there is, no reproductive health or, progeny, what we call it as, it leads into not a good population health and growth. So the importance of reproductive health is, it is crucial for the population health and growth. You can also see that it impacts gender equality and women's empowerment. Very essential. I think today's generation, we can see that men and women are in equal status because women are also empowered themselves. Women literacy is on the rise, and they are also more independent into their career development. So naturally, when you see to population health and growth, gender equality also has taken into consideration, and that is how women are also taking up higher positions and their career advancements are on the rise. So if you look into one more importance of reproductive health, it enables informed decision on reproduction. Yes, today I think though in Indian scenario or in the rural areas, men take the upper hand with reproductive aspects. But then, if you look into the literacy rate and more or less on the uh, health or in general the status, it has been seen that the informed decision is taken by both the couples. So naturally, maybe in terms of family planning, maybe in terms of you're planning a pregnancy or whatever it is, it's more or less the couple take an decision uh, both together. Okay, so this is also very important in terms of reproductive health. And one more thing is it prevents reproductive diseases and complications. When you look into what to say the decisions what is taken by um, informed decisions or couple decisions, overall you can see that more or less the disease conditions or the complications can be reduced a lot. That is why when you see the importance of reproductive health, uh, very many aspects may be there, but then these are few aspects overall for the future younger generation to take their work into or take them into their stride or take towards excellence. It's very essential that reproductive health is also taken into consideration. So we'll move on to the next. Next one, Narchana. Yeah. So if you look into the challenges in the modern era, you can very well see lifestyle changes. I think this is the important factor when it comes to reproductive health challenges. Many a times it so happens that your lifestyle has made you drastically have an impact on your reproductive health. May it be in terms of your diet, may it be in terms of your work pressure, may it be in terms of your family life, may it be in terms of your personal life. you know it's become so mechanical. It so happens that this lifestyle has led into lots of changes in the reproductive health. If you look into um, many a times it so happens that there are very many factors, but about 5 to 10% or maybe less than that also, maybe unknown reasons for which the couple are not able to conceive also will come into that infertility as such. But this is also a major concern because there is no problem in the couple, but still they are not able to conceive. Maybe again a stress which is taken into consideration. So lifestyle changes, when we say, it may be related to stress, may be related to your poor diet, or may be related to environmental factors, may be related to your work, working environment or occupational health, may be any sort of things. There are challenges which goes in for reproductive health. One more important aspect is your delayed parenthood and age-related issues. I think this is a very major concern because today, if you look into both of them are working, it is not the man works and the women are at home. Today, I think the impact or what to say, the concern or the challenges has been changed. And I think both are really striving hard to make the ends meet also. Not only that, women are also taking the lead role in more or less in almost all the organization. Okay, our nursing may be more or less into a women-centered profession, but then men are also into our profession. but nevertheless, women are really empowered so much so that there is delayed parenthood and age-related issues because career advancement is taken as a lead role compared to having a family of their own. And today, what has happened is you can very well see uh, every family, it's more or less a nuclear family. So, husband and wife are both working, and naturally, nobody to take care of the child. So, childminder should be taken care of. So, that is also an issue which they find it very difficult. That's why they think of postponing. And as age advances, the fertility level decreases. And naturally, this is again a challenge which is come across by more or less most of the couples. Social stigma around infertility is also a major concern. People have gone in for diagnostic measures and they've come across they are, having some or other problems, maybe a male or a female. There are causes related to that, but then people are, uh, having sort of what to say inhibition to go to an infertility clinic or some or other. It's more or less a social stigma which is leading them not to move forward and have this treatment. And not only that, treatment options, many a times this infertility treatments are all more or less very very expensive also. So next is exposure to endocrine disrupting chemicals. As you know, hormonal changes or most of the time your adulterations or whatever it is, chemical compositions, all have an impact on your hormonal changes in the body, which can again disrupt your fertility aspect. So this is also a major concern. Rising incidence of lifestyle diseases. You know very well. Lifestyle diseases may be in terms of diabetes mellitus, um, PCODs are all on the rise, which again is a major concern for infertility. And occupational exposure, as you know, heat related areas, chances of infertility is very common. So these are some of the challenges which we come across in the modern area. So lifestyle changes may be, or age related ailments may be, or maybe hormonal changes in relation, which can lead into having an impact on the ovulation, maybe having an impact on the sperm, production. And so it is in both the male and the female. These are the important factors which can have an greatest impact. Next slide, please. Yeah. So when it comes to infertility, all of us know for about an year or so, if the couple have been planning and the woman is unable to conceive, chances of infertility uh, is there. So, the inability to conceive after 12 months of regular unprotected intercourse, you call it as infertility. And all of us know there are two types of infertility, maybe primary or secondary. Primary may be from the very beginning, they have been trying, but still they are not being able to conceive. But then secondary infertility, she might have had one and then trying for the next, we are unable to conceive. So it can be either way, but more or less, infertility can have an impact on the couple, not only on the couple, it can have an impact on the family life also. Maybe the closer members of the family, or a disruption in the whole system of the family can take place due to infertility. So it affects both male and females. And if you look into the prevalence, you can very well see it's about 10 to 15% of reproductive aged couples are, having the problem of infertility. And as I mentioned in the earlier slide or in the very beginning, the greatest impact is on the emotional and the psychological impact. I know that is mental agony or the mental status is unbearable because the agony is only felt by the couple, not only by the couple, it's entire the family disruption is possible because of this infertility. So naturally, if you look into the prevalence, it is also about 15% globally. You can very well see. Next. Yeah. So when it comes to, I'm just giving you a brief overview on male infertility causes. You can very well see the low sperm count, which is the important positive factor. Fertility, wherein it may be leading to, and as I mentioned to you, the hormonal imbalances in the male factor. Also, genetic disorders or hereditary may be also a factor, and then lifestyle factors such as smoking, alcohol, and obesity. These are the lifestyle factors. And today, if you look into smoking, alcohol, and obesity, as it's a metropolitan city, most of the women are also into this because today, when we see smoking and alcohol, it is not only meant for men, more or less, women are also into it, where you can see more or less in almost metropolitan cities. So, these are some of the causes which can have an impact. So very important is a low sperm count, which maybe, or ejaculation factors, premature ejaculation. All these sometimes can lead into, infertility factors in or causes. As I mentioned to you in the very beginning, the exact cause is unknown. Mind you, exact cause is unknown. Many a times, as I mentioned to you, infertility without any reasons. Sperm count is also normal. Ovulation cycle is also normal in women, but the couple are unable to conceive. Maybe unknown factors, or maybe they're not aware of the ovulation cycle, or that is also a possibility. But many a times the exact cause is unknown. These are all predisposing factors which can have an impact. So these are some of the male infertility causes. Next one. Yeah. When you see to the diagnosis, we're not going into the details. I think somebody else is going into having some of the treatment aspects and all. So the semen analysis is the major component which is taken into consideration. Imaging techniques are there. Hormonal tests are also available. And like very important is with the lifestyle changes. Mind you, the simplest solutions, in fact, with the advanced treatments in relation to your infertility management, I think Sushmita is going to deal with it. But I'm telling you the commonest solution is more or less on lifestyle changes, which can lead into having a normal course of pregnancy outcome in many a times. So lifestyle changes and medications may be there. Surgical corrections for blockages may be a sort of treatment. Other than that, as all of you know, for infertility, assisted reproductive technologies are available more or less in almost all multi-speciality hospitals. Infertility clinics are available. Infertility treatment is also available, but it is only what happens with this is not all may be affordable for all these solutions. So best is go for a lifestyle modification, which will have an impact on having a regular course of pregnancy outcome many times. So these are some of the diagnostic measures which may be possible with male infertility. Next, we'll move on to the next slide, please. Female infertility causes. Having seen into the male infertility causes, when it comes to female infertility causes, I think the major component is the polycystic ovarian syndrome, which is having an impact on more or less almost, I can very well see more than 50% these days come across with PCOS or polycystic ovarian syndrome. It is mainly with the, uh, you know, cysts present, which will lead into, irregular menstrual cycles, and androgen insulin resistance can be there even into this male hormones present in the women in higher amount, that is androgens, which can lead into PCOS or PCOD, what we call it, as the very important factor which can affect. Again, as I said, it is the exact cause is unknown, but these are some of the causes, and the important cause is PCOS. And other than that, you also know fallopian tube is very important, or in the reproductive cycle or in the female reproductive system. As you know, ampulla is the area where the fertilization occurs, and at the time of ovulation, all of us know in the general fertilization and development of the ovum, it is the ampulla where the fertilization occurs. So, sperms have to traverse, and one ovum, that is the mature ovum, is taken up by the fimbriae and it comes to the ampulla, and that is how fertilization. So if there is blocked fallopian tube, uh, chances of pregnancy is comparatively lesser. Other than that, all of us know that any changes in the uterus or hereditary, where uterine or cervical abnormalities are there, fibroids are there, chances are there of infertility. And one more very important factor is, as we know, age-related decline in egg quality. That's that's why I think couple who are into that reproductive age group, and women especially between 18 to 45, uh, we say the reproductive age is between that, but then pregnancy after 35, or as the age advances, the motility, the quality of the egg may be hampered due to age, and that is why decline in pregnancy can occur. So, age-related decline in egg quality may be a factor which has been found, and a study also is conducted at the with the American Society of Reproductive Medicine, or American College of Obstetrics Gynecology, where they specifically say that um, by age 40, the chance of natural conception drops, and compared to 20 to 25% in women under 30. So, pregnancy, if we have to see, I think it's best to go with the early pregnancy rather than delaying it for the late pregnancy. In fact, not that all will have problems, but about, as we see here, some percentage may go in for infertility as the age advances. Naturally, very important factor with female infertility is more or less on PC ovaries. Next. Here also we have this ovulation testing, ultrasound, laparoscopy, hormonal treatments are also there, which can induce ovulation, surgical interventions or corrections of the blockages. And as you know, the important advanced treatment for a solution for infertility, we do have various assisted reproductive technologies, which is a boon to more or less uh, the couple who are genuinely having problem with fertility is assisted reproductive technologies. And one more very important is surrogacy. I think surrogacy also has its own ethical considerations. If somebody is going to deal this after, later on in the session on the ethical aspects, where they may tell you about the surrogacy also. It's a very good aspect, surrogacy, where a woman is unable to have, the pregnancy continued by these reproductive technologies. Naturally, surrogacy is a part of it, but then surrogacy can lead into issues. There are some ethical issues which can have an impact on the growth of the further child further also. So this is one concern, but otherwise it's a very good option. Not only surrogacy, you can very well see a solution is more or less on adoption also. Today, there are very many adoption centers where they legally go about with adoption techniques. Very important aspect which has come into a boon for these couple who are unable to conceive, or many a times with assisted reproductive technologies. It so happens that so many cycles they have underwent, but still the conception rate is comparatively lesser because failure rates are more with assisted reproductive technologies also. So naturally, the couple may be, spend money, but they're unable to conceive. They may drop out from going in further for this treatment. So naturally, adoption is again a boon, and that's a way forward, which is been coming up with these couples who are taking into the and it's like more or less the child is going to get a life from this couple also. So that is what is a solution. Next, please. Yeah. If you look into the global scenario on infertility, Europe and East Asia are facing fertility decline. Widespread use of ART in developed countries, assisted reproductive tech. See, one more very important aspect is some of the couple may think of, not having, because of their career advancement, may not think of having the pregnancy now. And we have come across many studies saying, or many live experiences where when we go to a fertility clinic, without the disclosure, it is more of a confidentiality. They say this has been preserved so that they can have it later. So these are chances are there, women going or the couple going for that also. So ART is widespread in developed countries. Access disparities in low-income regions. I think because of its cost effectiveness or the financial component involved with infertility treatment is very, very high. I was just going through some articles where, somewhere it was there. I think insurance coverage should be there for, this thing, which is again an important aspect because it's more or less like medical treatment. So I don't know how far it may come up, but then people are raising their voice saying that infertility treatment should also have medical insurance, which again may be debatable. So access disparities in low-income regions is mainly because of its financial constraints. And one more very important thing is global research collaborations on reproductive technologies. These are also going on, because ART on the whole, there are both pros and cons, but very well for the infertile couple, I think ART has been a boon. So it's more or less more of advantages when it comes to conception. But then the fertility rate is not very, what to say, I mean, it is not very much there. There are chances of failures. That is why, lots and lots studies or collaborations are going on. Next, please. Yeah. If you can again see with the global scenario with the fertility decline in Europe and East Asia countries like South Korea, you can very well see the fertility rate is very less. Japan, Italy, and Spain also is very, very less. Almost globally, I think today the fertility rate is declining. It's very much alarming. So rising use of assisted reproductive technologies in developed nations. Over 10% of births in Denmark result from assisted reproductive technology, which is the highest proportion globally, they say. So naturally, global scenario also, if you look into the fertility is declining, maybe because of the environmental factors. Your dietary component is more, it is said that the burgers, the pizzas, the diet which has a greatest impact on the hormonal imbalance, which can lead into not having the normal growth of reproduction. Next, please. China, next. With Indian scenarios also, you can very well see rising infertility rates due to lifestyle and urbanization, increased awareness but persistent stigma, growing assisted reproductive technology industry and fertility clinics, and government initiatives like the National Reproductive Health Programs. Not much on fertility or infertility aspects is taken care of. NRHM, National Rural Health Mission, what to say, Janani Suraksha Yojanas are all, or, maternal and infant care, that is newborn Suraksha, we call it as Shishu Suraksha Karyakram. All these are there, a boon for the mothers and the infants, but with infertility, not much government initiatives are there, but as such, I think more or less people don't take, what to say, because of the stigma, people don't, go into these sort of treatments. And not only that, financial, as we have been time and again saying with previous slides also, the financial component is on the rise. So in Indian scenario also, you can see fertility is rising. Main thing is, I told you, it is urbanization. When it comes to urbanization, more or less people are into stress, stress. It's become so mechanical with the work pressure. People, the what to say, you do not have time for each other. That is what is the component. Many a times it so happens that both are in different shifts where they may not be able to have family time together also. So this is how urbanization has taken place. And when it comes to lifestyle, all of us know that both working, it is not possible for you to have your free time to cook, and that's why lifestyle diseases are on the rise, because your diet goes in for having more or less, packed food items. So this is how is in India also. Next slide, please. Yeah. This is just a statistical overview of how urban area factors have, led into infertility, maybe delayed marriages, late childbirth, sedentary lifestyle, stress, and environmental impact. And that is really going on the rise. Though sometimes it is not only with the delayed marriages, couple have been married early, but they do not want to, have a child for quite a long years. And today, if you see, I think most of the couples are not opting for going in for having children also, because this is the trend these days we can come across, because they are all into career advancement, and more or less, they think who will be there to take care of the child if they have a child of their own. These are some of the aspects which are real challenges. But the beauty of it is, as a mother, to have a, child of your own in the reproductive age. So increased awareness, but persistent stigma, as I've told you in the earlier slide also, you can very well see it's really somewhere as close to average of about 48% is there, but then about 23% of women report emotional distress due to infertility, and over 70% experience societal pressure and stigma related infertility. And not only that, family also, have a greater role to play in bringing about emotional impact on the couple, infertile couples. And many a times it is only the women who are focused more on when it comes to infertility, because maybe the cause with the man, but women are only, stigmatized. This is also very, very common. It is not always the women are having the positive factor. It may be men also, but more or less the focus is only on the women. That is why the women feel more of, psychological impact. Next. Yeah. So this I think somebody is going to deal with, but overall you can very well see these are some of the factors which are there, which can have an impact. So ethics plays an important role when it comes to infertility. Last slide, please. Next one. Next one, Archana. Yeah. This is the psychological impact of infertility. As I told you, emotional distress and anxiety, relationship stress, support groups and counseling are needed, importance of empathy and awareness. So remember, as I told you previously also, women are only targeted, though it is not, they are, they are not the, they do not have any problems with positive factors. It is with the men, but still they are only targeted. So psychological impact is so much. So emotional assurance, or more of psychological assurance, stress free, and a family bonding is very much important. I think the role of family here may be in-laws, or maybe the husband's family, or maybe your own family, all have to have a greater bonding with the woman couple as such, but women as such is very much important, so that women are not targeted for the infertility. So naturally, empathy is an awareness about what is infertility and how what factors can lead into infertility can be made aware of by educational aspects. So you can very well see, invest in awareness and education, improve access to fertility care. As I told you, I think fertility treatment is very, very costly, and not all are able to bear the, uh, expense of this infertility treatment. So naturally, access to be there for this fertility care. Then support, research, I think today evidence-based practice is on the rise. Every bit of it is with evidence, which is taken a long way because of technology advancements. I think in vitro fertilization, or any other aspects of reproductive assisted reproductive technologies have made a what to say global impact on the infertile couple. And one more very important thing is ensure ethical standards in treatment. Very, very essential. I think when we face, when we go with ethics, I think the couple are also safe, and the professionals who are into, looking into the treatment sort of it are also on the safer side. Not only that, it becomes really easy for everybody to have a standard of care based on the ethics. So this is very, very essential. Overall, I feel reproductive health challenges are there. Challenges in the modern era are very many, but it is the way forward is many times to have an awareness and education is mainly on the lifestyle modification. I can very well say a lifestyle modification and a beautiful dietary component. So it can prevent the diseases. It can also have a beautiful, healthy lifestyle in relation to you having a good impact on the reproductive health. So this is what is the modern era challenges, and the way forward we can carry with. Next. Yeah. I think anybody wants to have an overview I think we have just focused on the basics of the common challenges what the couple face or reproductive health challenges and an overview on the infertility. Thank you so much for giving me an opportunity to be a part of this national workshop. I would have enjoyed being with you all there in the college, but nevertheless, it was a great opportunity, Dr. Jorley. I'm thankful to you
Ma'am.
for this webinar. Thank you so much, and to all the organizers for giving me an opportunity. And I wish the participants for a patient hearing from me for about 45 minutes or so. I'm sorry for the delay, what has occurred, but nevertheless, I'm thankful to you all once again for giving me an opportunity. Thank you.
Ma'am, there are some questions. Dear participants, if you have any queries, you can type your questions in the chat box. Or you can unmute and ask. Ma'am, there is a question. How do reproductive health issues differ between adolescents and adults? Ma'am, I repeat, how do reproductive health issues differ between adolescents and adults? Please unmute, ma'am. We are not able to hear. Please unmute, ma'am.
Hello, can you hear me?
Yes, ma'am. Yes, ma'am. Now.
Yeah. See, a girl when she's born, or I mean, hello.
Yes, ma'am. Now it's
Okay.
clear.
See, an adolescent turns into an adult. So only when you have a lifestyle modification during adolescent period, you can go in for a healthy lifestyle in the reproductive period in the later life. Though we say reproductive age is between 18, I mean, a woman, once she is menstruating at the age of 14, she is able to, reproduce. But the quality of the eggs are not that mature. And she is also not fully matured enough to bear the brunt of pregnancy. So naturally, if your lifestyle modification is from the very beginning, that is why we say obesity, PCOD, are the major factors which can lead into, having a later life reproductive health challenges. So from the period a child is, taking the maturity comes or the menstruation comes, irregularities occur maybe initial period because of the hormonal changes, but as such, your dietary component, your stress can lead into having more or less on the polycystic ovarian, because this is the major component which is affecting the females, which is again triggering to the later stage. That is how it is. See, there is no much of a difference between reproductive health during adolescence and later stage. It is carry forward from. So if you have to have a healthy reproductive health, it goes along with the adolescent period, so your lifestyle or your diet plays a very important role. Are you okay?
Thank
Hello?
you. Thank
Hello?
you. Thank you, ma'am.
Yes.
You are audible, ma'am.
Okay.
There is one
Yeah,
more question, ma'am.
Yeah.
What misconceptions do teenagers often have about reproductive health? I repeat,
Okay. Hello?
what
Yeah.
misconceptions do
Yeah.
teenagers often have about reproductive health?
misconceptions, is it?
Yes, ma'am. Yes, ma'am.
In relation to reproductive health.
Yes.
Many a times, what happens with teenage, that period is more of what to say, wavering. You got it? It's more of wavering. And naturally, the girl or the boy naturally have a tendency to, have that. What to say, infatuation towards the opposite gender. So here it is more or less, I think, values, what to say, education, or more or less on the what to say, awareness, which is required maybe at the school level. That is why today I think reproductive health education or sex education is a part of the school education, where it has come into picture. So to avoid this misconception of reproductive health, only thing is we need to give awareness regarding having, that is why, no, what to say, good touch, bad touch, all these are aspects which is very much made evident in the schools these days. And we do give more of awareness talks on the menstrual hygiene, sex education, so that they don't go in for an, what to say, having a pregnancy prior to, marriage. So these are all to be preventable. The misconceptions are mainly related to sex education. One is they feel that infatuation, and naturally chances are they may fall in as a prey. Rape is very, very common. And not to, and one more thing is, see, as the body has the changes, they feel that something is going on in them. So it is mainly the mother needs to, educate, and there should not be any, feeling that, oh, how can I disclose? It's only, see, it so happens that many a times it is only with the peer group where they get into so many things. I think awareness should be there from the very beginning. I think today, with the more or less educational component, schools are also there, and the mother is also able to, you know, uh, educate the child as to this is a normal process, nothing to be stigmatized. Otherwise, earlier and all, people used to sit at home when there are periods and all. But today, I think that's all gone, and people go forward on all those days also. And it is more or less everything on reproductive health is become more aware in, as a part of sex education in schools. Anything else? If anybody can add, no issues. Hello?
So far, this is the only questions we have received, ma'am.
All right. Okay, okay.
Thank you,
Am I
ma'am.
okay? Oh, yeah. Thank you so much, Dr. Jolly, Archana, and all others. Can I leave? Hello?
Yes, ma'am. Thank you
Yeah.
so much, ma'am. We are
All right.
incredibly grateful for
Okay.
the valuable knowledge you have shared with us. Thank you so much.
Yeah. Thank you so much. See you. Yeah. Bye.
As we start this journey of knowledge and collaboration, it's my honor to introduce our esteemed resource person for this session. Today, we have the privilege of welcoming Dr. Sushmita Ramana Kakada, Associate Professor, Manipal College of Nursing, Manipal Academy of Higher Education. She has completed BSc Nursing in 2003 from Fadamulla College of Nursing, Mangaluru, MSc Nursing in 2008 from Manipal College of Nursing, PhD in 2018 from Manipal University of Higher Education. Dr. Sushmita's professional expertise is primarily centered around enhancing midwifery practice, neonatal well-being, menopausal health, and interprofessional education and practice. Her dedication to these areas of specialization is evident in numerous publications in esteemed international healthcare journals. She has also completed her FAMA fellowship from M. Philippe Mahi, Manipal, currently pursuing International FAMA Institute Fellowship 2025 batch. Furthermore, She serves as a valuable reviewer for international nursing journals. Dr. Sushmita's commitment to nursing education and research continues to make significant impact on the academic and clinical aspects of the profession both nationally and globally. Without further ado, let's give a warm welcome to Dr. Sushmita RK. We eagerly await your presentation and look forward to gain new perspectives from your expertise. Over to you, ma'am.
Thank you. Thank you for that introduction. Am I audible?
Yes, ma'am. Yes.
I'm just sharing my slides. Are my slides visible?
No, ma'am.
One second.
Ma'am, any issues, ma'am? Ma'am, hope you are there online. Our host will be joining us soon. Please wait.
Next, section 2, advancement in infertility treatment and integrating alternative approaches to fertility.
Our speaker will be joining us soon. Please wait.
Hello.
Yes, ma'am. You're audible.
Am I audible now? I'm sorry for the technical glitch. Are my slides visible now?
Ma'am, it's not full screen, ma'am.
Now,
make it slideshow.
yeah, is it in slideshow now? Hello? I've put it to slideshow. Is it still the same or?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Is it in slideshow now?
Yes, ma'am. Now it's in slideshow.
Okay. Uh, Sorry, everyone. And once again, good morning to all of you, all the participants and all the organizers. At the outset, I would like to thank the organizers for giving me this opportunity and hope I will do justice for the topic which is given to me. So the topic for the session is advancements in infertility treatment, a new era of hope. So we have seen infertility couples very often, day in and day out. We have seen them in the clinical area, or we have seen our own family members suffering of infertility. So today's topic, it covers the breakthroughs and the technical innovations that has happened, and what are the future paths for this infertility treatment. Well, just to show you some idea, and if you have any doubts, you can ask me. If I'm able to answer you, I will be happy, or else maybe I can refer and I may let you know later.
Ma'am, excuse me.
Yes.
Your video is off, ma'am. We are
Yeah,
not.
I've off the video because
Okay.
maybe with the video on, there's a concern, so I've off the video.
Okay, ma'am. Thank you.
Yeah, yeah. So the infertility crisis is a growing need. So every year, I mean, this is the latest data in the year which is published by WHO in the year 2023, which reports that 1 in 8 couples worldwide face infertility challenges, and the prevalence estimates are 17.8% for adults in higher income countries and 16.5% of adults in low and middle income countries. The prevalence rates are almost alarming. And infertility prevalence generally rises with increasing female age. So female age 30 or 35 years above, they are at more risk of having infertility in future. And there's fourfold increased prevalence of infertility in nulliparous individuals when compared to primiparous or multi gravidas. And we already know about in vitro fertilization, which is used to treat infertility. So can anybody tell when was first IVF baby born in the world? Yeah, of course, I've written 40 years ago, but it's not this correct year. Anybody among the audience? Which year was the first IVF baby born? Okay, it was in the year 1978. The world's first IVF baby was born, and it is estimated, after that, it is estimated that over 8 million infants have been born as a result of IVF or infertility therapy. So, this is the view of infertility worldwide. So some of the ASRM is American Sexual Reproductive Management. They define infertility as a disease or a condition or a status characterized by one of the following. Okay, otherwise we say that infertility is inability of the couples to become pregnant within 1 year of unprotected sex, or any other measures taken for contraceptive measures. But ARSM defines infertility as a condition or a status when there is one of the following. The first one is the ability to achieve a successful pregnancy, which are based on patient's medical, sexual, and reproductive history, age, physical findings, diagnostic testings, or any combination of those factors. Or the need for medical interventions, including but not limited to the use of donor gametes or donor embryos in order to achieve a successful pregnancy, either as an individual or with the partner. Okay, I will tell you about this donor gametes and donor embryos a little bit later. Or the other condition might be in patients having regular unprotected intercourse and without any known etiology for either partners suggestive of impaired reproductive ability. So both the partners are normal, and evaluation should be initiated at 12 months when the female partner is under 35 years of age, or at 6 months when the female partner is above 35 years of age. Okay, so this is the general definition of infertility given by ASRM. There are various other definitions given by ACOG, FOXY. There are many definitions. Based on these definitions, the rate of infertility treatment or the success of infertility treatment depends upon. So here I would like to show you one slide which tells you which you should understand when or the timings for the infertility evaluation. When a couple should seek consultation for infertility. So it is like the first one, it says that initiate evaluation after 12 months of unprotected and frequent intercourse when the woman is aged under 35 years and she's not having any risk factors for infertility. This I've only taken for female infertility. There is a guidelines for male fertility also, but I've just taken out the female infertility. Okay, the second is you have to initiate evaluation after 6 months of unprotected and frequent intercourse when the woman is aged between 35 to 40 years. You see the difference of the time of evaluation. Okay, and then the third one says that initiate evaluation upon presentation despite of the timings of unprotected and frequent intercourse when the woman is aged above 40 years, when she has oligomenorrhea or amenorrhea, says that she has some menstrual problems, women with the history of chemotherapy, radiation therapy, or with advanced stage of endometriosis, again says she has some gynecological problems, women with known or suspected uterine or tubal diseases, or women whose male partner has a history of groin or testicular surgery, adult moms, impotence or other sexual dysfunctions, chemotherapy and or radiation, or a history of subfertility with another partner. Okay, so these are the indications or the timings when a couple should seek evaluation for infertility. Okay, so when you come across patients or when you come across your own family members, maybe you can give them this information. Okay, so what is the current landscape of infertility treatment? We go with all these traditional treatments, like we have medications like ovulation induction tablets like clomiphene citrate or some gonadotropin releasing hormones. So all these boost the ovulation and it releases the ovum or eggs for fertility. Okay, and there are some surgeries which has taken place, like if there is a cervical stenosis or a uterine stenosis. So just to broaden the pathway, so some surgeries can be conducted, or myomectomy. If myomas or fibroids are the reason for infertility, so surgeries like myomectomy can be done, and intrauterine insemination. This is a very common treatment option in
Excuse me, ma'am. Ma'am, it's not audible, ma'am. Ma'am, hope you are there online. We are not able to hear you, ma'am.
Am I audible to?
Sorry for the inconveniences. Sorry for the inconvenience. Please wait till our speaker is back online. Please wait till our speaker is back online. Sorry for the inconvenience.
I'm extremely sorry. I don't know why I'm facing this problem. Am I audible now?
Yes, ma'am.
Yeah, I will share the slides.
Okay.
Are my slides visible now?
No, ma'am. It's showing Aza has started screen sharing.
Okay. So far, was I audible so far?
Yes, ma'am.
Okay, so you followed because I just interrupted to ask whether you all are with me, so I lost the track again.
Excuse me, ma'am. Note the slide, ma'am. Previous.
Yeah, till here, was I audible? Or should I?
No, till previous slide, ma'am. Nancy.
So is it audible and visible now? Hello?
Yes, ma'am.
Are the slides visible and am I audible?
Yes, ma'am.
Okay. Okay, so we have seen all the traditional methods. I've told you what are the traditional treatments and what is the success rate. But now, since we want to know what is the cutting edge research or what is the uh, advancements that have happened, I'll be going on with one by one. So, first one is improving the oocyte quality, the role of mitochondria. So, mitochondria which is in a cell. It plays an integral role in maintaining the quality of oocytes. So, at the age of 30 in humans, the majority of the tissues have lower, this is coenzyme Q10 concentrations. Okay, so this is a coenzyme which is found in all the cells, and after the age of 30, this enzyme, this coenzyme Q10, it becomes deficit, or it is deficient, and that is why when the women above the age of 30 face infertility issues. Okay, so the new innovations here is coenzyme Q10 supplementation, which has been introduced now, and it is found advantages in IVF as it improves the oocyte quality. Earlier, we were having medications like clomiphene citrate to boost the ovulation. Now, there's a switchover, and there's a role of coenzyme Q10, and it has been there are studies going on, and this coenzyme is found to be very effective. So usually what happens is a woman's procreative capacity declines in the fourth decade of her life, and which is directly tied to an age-related decline in the oocyte quality and quantity. So also whenever there is a advanced oocyte aging or the ovarian aging, it is always associated with chromosomal aneuploidy or chromosomal abnormalities. So to boost up this ovulation, the quality of oocyte, coenzyme Q10 is supplementation can be given to the women above the age of 30 years. Okay, and what does this do? It can be given in vitro and in vivo as well as in vitro. Okay, so this procedure of maintaining or supplementing coenzyme Q10 can be accomplished by two methods, in vivo and in vitro. In vivo, there's a oral treatment methods which are given orally. These coenzymes are given orally to enhance the oocyte quality. Whereas the second feature, what you're seeing in vitro, what is done here is the culture media is supplemented with enzyme, which can be further used as a standard culture or in vitro mutation culture. Okay, so one is done orally, another one is done externally. These two combinations can be done with coenzyme Q10 supplementation. Okay, now let's go to some breakthroughs in IVF technology. Okay, so
Ma'am. Ma'am, you are not audible. Ma'am, hope you are there online.
Hello.
Yes, ma'am.
Is my slide visible?
Yes, ma'am. Now it's visible. It's already slideshow, ma'am. Ma'am, we are not able to hear you, ma'am.
Yeah. I'm not started. This is where sperm analysis or to detect the I mean, quality of the oocyte. So now there is AI which has come, which is pitched in to do some diagnostic. It is favoring diagnosis of the for infertility treatment. So first one is sperm analysis. So here, the sperm analysis, it gives 90% accuracy of assessing motility and morphology. So what does it do here? It uses the sperm ultrastructural and kinetic data, the AI, the machine learning. It uses the sperm ultrastructural and kinetic data, and it's almost 90% accurate in classifying the sperm motility, and it also outperforms the manual assessment in reproducibility. And also one more feature is it detects the markers like sperm morphology and motility up to 94%. So earlier, this was not done. Only the motile sperm was picked up for the IVF treatment, but with AI, it now it gives more accurate findings. And also next is ovarian assessment. Also, AI helps in predicting the response to stimulation protocols. After the ovarian stimulation, the AI helps to assess the ovarian function, and also to see whether ovulation has taken place in time, and also uterine health, because there are a lot of data sets which gives accurate uterine health, because AI helps in identifying abnormalities with multi data advanced imaging protocols. And also AI has shown its part in genetic screening, which analyzes the data to predict the embryo viability. Also, there is something called as embryo selection and ranking. So when the ovarian health is assessed, so it identifies the subtle markers for embryo viability, and also supports prediction of blastocyst formation and potential live births. So there are various the clinics are there which uses this AI powered diagnostic to report higher implantation rates. And also it also helps in reduction of variability. And also the multiple studies have shown that using AI powered diagnostic helps to confirm the diagnostic concordance, and makes the couples more open for treatment and diagnosis. So other things are this tuple, other advancements are there's something called as time lapse imaging. So what happens here is the time because it identifies a suitable time for the embryo to grow. That means it takes embryo growth continuously for better for better selection decisions. And also this, I've already told you AI in embryo selection, which helps in selecting the best embryo, so that this 20% accuracy rate, and also it boosts the success rates. There's something called as microfluidic sperm spot sorting, and also wearable hormone monitors, just like how you have your smartwatch and things like that. Some dermal patches or wearable devices are available which predicts the hormonal levels, and it also gives you the ideal time for implantation or ideal time for ovulation and things like that. Let's see one by one. First one, let me come to time-lapse imaging. So what happens here is this is used to see this continuous monitoring, because it provides a real-time observation of embryo development without disruption. Okay, so that is called as time-lapse imaging, and it is done in an undisturbed environment. Like embryos remain safely in the incubator throughout the observation, and it gives you a comprehensive data. Means there are lots of images per embryo is taken off, and based on these images, a healthy embryo or a good embryo is selected, and it is transferred later. Okay, so how does it work is there is a specialized incubation. There's a incubator here with integrated camera systems, and it maintains optimal growth conditions. Okay, so the embryo, when it is transferred, when the oocyte is transferred here, it is transferred into the incubator, then it is continuously, there's a video compilation. In the sense, there's sequential images which are taken, and they are compiled into time-lapse videos showing the complete development of the embryo. Okay, and then later there's an automated analysis. Here the software tracks the precise timing of cell divisions and embryology and the morphological changes that happens, and it allows the good selection of the embryos. Okay, so benefits over conventional methods is earlier conventional methods, there is early detection, because it identifies the developmental abnormalities that the traditional method would often miss. So it detects, there is early detection of this good embryos, and it catches the subtle irregularities in cell division pattern. Okay, and also there is enhanced accuracy in terms of objective data, which is used for embryo selection decision, and it also relies on quantifiable parameters rather than the occasional observations. When it is done as a traditional method, there is a person who is or the scientist who is observing all these things, but now everything happens in machine learning. So there is a computer or the software which tracks all these things, and hence it gives accurate results, and also there is reduced bias, okay, than the human tendency of committing bias, and also it gives standard evaluation criteria across all embryos. Okay, so time-lapse method is it has a 33%, 33.7% live birth rates with the time-lapse technology, and 81.3% of implantation rate, and this is proved in clinical studies. And a biggest benefit is women aged 38 and above. Okay, it helps women who are aged 38 and above to take up this technology, so that a good embryo is selected and it is processed further. The second one, what I was telling you, was embryo selection, AI in embryo selection. So what does it do is embryos are selected in choosing, AI is used here in choosing embryos with the highest potential. So it leads to successful pregnancy, and also it leads to accurate embryo selection. Okay, so with this, there is a quality assessment which identifies the viable embryo through evaluation. Okay, so with the time-lapse technology, you identify the exact time, and then using the AI, you can go for the embryo selection. Okay, and why this is very useful is because traditional methods rely on visual grading by the embryologist, whereas here there is a machine learning, or there is a software or the NLP which uses the components to identify the healthy ones. So this introduces subject variation that can affect the outcomes. Okay, and even here, how AI analyzes embryos is there is an image capture. So which there is a continuous time-lapse photography which collects the developmental data, and then the NNN, the neural networks, it analyzes the visual pattern. This is how the AI processing goes on. And then there are algorithms which predict the implantation potential. Okay, so this purely this is the AI which uses machine learning to select and identify a good embryo. So AI leverages existing data without requiring invasive procedures, and this preserves the embryo's integrity. Okay, the main thing when the embryologists, when they pick up the good embryo, there might be chances for damage, but here there is no embryo damage because it maintains embryo integrity throughout the analysis process, and research confirms AI model match or exceed the expert accuracy, and they eliminate the variability seen in human assessments. So this is very useful. And how do they do this is the notable AI models in practice are there's something called as deep embryo, time-lapse analysis, and automated grading. Okay, so what do they do here is deep embryo is they predict the pregnancy outcomes with 75% accuracy using 3-point time point images. Okay, with this 3-point images, they select the best embryo. And then there's something called as time lapse analysis. Again, the entire developmental process is videographed, and it is code. Okay, and then it is graded. Like the deep learning, it helps to assess the blastocyst quality and the developmental timings. So these systems, they integrate seamlessly into the existing clinical workforce, and which provide rapid, consistent embryo evaluation. So what is the clinical outcome here? So there's 30% of improved selection of the embryos, and 40% of the time is saved of the embryologist, and it allows 60% standardization. So consistency of the embryo evaluation across the clinics. So it helps to follow a standardization. So therefore, AI tools integrate with the existing equipments and reduces the implementation cost while maximizing the benefits. Okay, so the next one is microfluidic sperm spotting. So this is a technology which is transforming how to select a sperm for a fertility treatment. Okay, earlier we were doing sperm wash and all those things, but now this is more accurate technology, that is microfluidic sperm spotting, and this is a cutting edge approach which improves conception rates through precise sorting mechanisms. Okay, so the challenges of sperm selection for traditional methods was the embryologists were using that swim up and density gradient configurations to identify the correct sperm or the motile sperm, and with this technique, some of them could cause damage the sperm DNA. Since now the damaged sperm DNA, when it is introduced, it led to failed implantation, and it also failed IVF cycles, and also patient because of multiple failures, they face emotional as well as it is too much expensive, so it caused financial burden. So this was the need for innovation of bringing out or inventing microfluidic sperm spotting, MSS. Okay, so here they often select sperms with suboptimal characteristics, and the recovery rate typically ranges from 5 to 20%. So how does this work is the sample, the semen is allowed to enter into this micron size channels on a chip. If you see this diagram, I'm not sure this is the accurate diagram. I got it from a study. Okay, there are various tools which I use, but this is one of them. So this is called as MSS. So the semen is introduced into a micron sized channels on a chip, and then sorting is done. So healthy sperm navigates towards the network based on the motility. So there are multiple channels here. For example, say there are 3 channels, first, second, and third, or layers. So the how do they identify the good motility is when the sperm is able to reach the third layer or the third channel. They say that it is a highly motile sperm, and they sort it out. And then the collection is done. The top quality sperm accumulates when it is accumulated in the third layer. It is collected and it is analyzed. The quality assessment is done before fertilization. So this is how it works. So the key benefits of this technology is there is a superior DNA integrity because sperm is selected with minimum DNA fragmentation, and it also reduces the risk of implantation failure and miscarriage. And also this is very time efficient because it can be done within 30 minutes, whereas traditional methods, it required 1 to 2 hours to sort out the motile sperm. And it is again a non-invasive selection, and it gives a improved clinical outcome. Like studies have showed 30% higher fertilization rates and pregnancy rates increased by 25%. Okay, so these are some of the commercial devices which are available. So Zymot, Fertile Plus, MSS. So these are some of the devices which helps to sort out the or which helps in microfluidic sperm sorting. The next one is genetic screening and diagnosis. So we've heard about, or you might have seen or heard about pre-implantation genetic screening and non-invasive pre-implantation genetic screening. So here it is before the implantation. They screen the embryos to detect any genetic disorders early, and with this there is an increase in the implantation rate by 15 to 20%. And when it is in non-invasive PGT, here it is done non-invasively. They analyze the DNA from embryo culture medium, reducing the risk, and also the expanded carrier screening identifies the parental genetic mutation. Just to tell about what is pre-implantation genetic testing. So here, what happens is they screen the embryos for genetic abnormalities before IVF transfer. Okay, and this is an advanced technique which reduces the risk of miscarriage and also the transmission of genetic disease. This is to be very clear. So pre-implantation genetic testing is done to reduce the miscarriage risk and also to reduce the transmission of genetic transmission. Okay, and PGT plays a rapidly growing role in modern reproductive medicine, and it offers hope to couples with genetic concerns. Now, what does this PhD means? Okay, so it is rapidly growing role in modern reproductive medicine, and it offers a hope to couples with genetic concerns. Okay, earlier genetic concerns, genetic abnormalities were only seen with the after the implantation, but now it can be done before implantation. Okay, so comprises a group of genetic assays used to evaluate the embryos before transfer to the uterus. So there are 2 types of PGT, PGS and PGD. Okay, PGS is genetic screening, pre-implantation genetic screening, where it screens for chromosomal number errors like aneuploidy, which helps to prevent miscarriage and implementation failure. Whereas pre-implantation genetic diagnosis, it helps, these are the tests to identify specific inherited diseases. Okay, so targets known gene mutations in family with genetic concerns will be diagnosed with PGD. Okay, so PGS and PGD. It's better if you know the differences. Okay, so how it works is first the embryos are created. So embryos created through IVF and cultured to day 5 to 6. It reaches up to the blastocyst stage, and then the biopsy is done, embryo biopsy, and then the analysis is done, the genetic analysis is done. The cells are examined for any genetic or chromosomal abnormalities, and after that the embryo is selected. An unaffected embryo is selected for transfer to the uterus. following PGT. Okay. So benefits is there is 50% live birth rate and 70% miscarriage reduction and 99% disease prevention. This is very important. 99% of the inherited genetic conditions can be prevented with PGT. Okay. So then moving on to advances, what are the advances in fertility preservation? So far we were seeing everything about diagnosis and different techniques. Now we are seeing something about preservation. There's something called as egg freezing. Okay, so this allows like now more of the females are career oriented. So definitely the marriage age is advanced. So after that the childbearing age also is advanced, and there is ovarian aging. So egg freezing helps to freeze the eggs, fresh eggs, under the age of 35. Okay, egg freezing. There's something known as ovarian tissue cryopreservation. This is very helpful for cancer patients to preserve their fertility prior to treatment. I have a close understanding with this. One of my close relative, she had a breast cancer, and she was very young that time. She was just 35 years old, and she was married for 8 years, and she had this infertility problem. So before going into cryopreservation, so I mean, she wanted to do this egg freezing, but before that, investigations were carried out. They usually see this AMH, anti-Mullerian hormones. So if the hormones is, if AMH has a good quality or a good score, then egg freezing or ovarian tissue cryopreservation was possible. But she had her AMH at a very low level, so she couldn't go for this ovarian tissue cryopreservation or egg freezing. Okay, so any cancer patients, young age cancer patients, they can go for this ovarian tissue cryopreservation prior to chemotherapy. And also there's something called as social egg freezing. So this is becoming increasingly popular among women in their 20s and 30s worldwide. There are so many egg banks where the women can donate the eggs. Okay, it's just like sperm banks. There are there are egg banks too. So some of the innovations in drug therapies, there's something called as GnRH antagonist. So what does this do is it enhances ovarian stimulation protocols with fewer side effects. Earlier, the GnHs had more of side effects like OHSs. It's one of the terrible and the most common side effects. So GnRH antagonists have lower OHSS, ovarian hyperstimulation syndrome. And also there's something called as kiss peptine. Okay, so use, which is a new ovulation trigger alternative with improved safety profiles. What does this do is it directly stimulates the release of GnRH, which in turn triggers the release of luteinizing hormone and FSH from the pituitary gland. And it is beneficial in treating infertility because it's directly related to hypogonadism, unexplained fertility, and there are many studies which suggest that kisspeptine can play a vital role in improving the sperm quality also. Okay, and there's something called as stem cell therapies, which are more innovative therapies now, which shows promises in restoring ovarian functions, and there are still clinical trials going on. So what it is it is using the body's own regenerative cells to address issues like low ovarian reserve or damaged reproductive tissues or impaired sperm productions. So these therapies can involve involve regenerating ovaries to produce eggs, or it repairs uterine lining, or it enhances the sperm production in males. Okay, the stem cell therapies, and there are a lot of clinical trials which are going on, which shows that there's 20% improvement in ovarian reserve reported in the studies. What is the future now? We had seen past, present, and what is the future? So future, there's something called as artificial gametes, uterine transplantation, mitochondrial replacement, and in vitro gametogenesis. This looks all fantastic, but we actually don't know. It's still under trial. So artificial gametes, I'll come about this little more detail. So this is creating eggs and sperms from the stem cells to expand the reproductive options. Okay, and I'll tell you for whom it is more beneficial. There's something called as uterine transplantation. Just like how we have other organs transplantation, there's also uterine transplantations, which provides new hope for women without a uterus to carry pregnancies. Okay, and it is a surgical procedure where a healthy uterus is transplanted from a donor to a recipient, okay, who lacks a functional uterus or who has a diseased uterus. And this procedure offers a potential treatment for women who are unable to conceive or carry a pregnancy due to absolute uterine issues. Okay, so donor is selected here with the help of the surgically removed from the donor and transplanted surgically into the recipient's abdomen, and then the recipient will receive a lot of immunosuppressant medications just to make sure that the body doesn't reject the transplanted uterus. And then before the transplant, the recipient usually undergoes in vitro fertilization to create and freeze the eggs. Okay, and then the embryo transfer is done. Once the transplanted uterus is functional, the frozen embryos are transferred into the uterus, and if it results in pregnancy or childbirth, if there is implantation. Okay, once the desired number of pregnancies are achieved, then the transplanted uterus can be typically removed back. Okay, so this is what the process of uterine transplantation. Mitochondrial replacement it's also known as three-parent IVF, where we have two biological parents and one donor. Okay, so how is this technique is? It is a technique which is used to prevent the transmission of mitochondrial DNA disease. Okay, so here it replaces women's egg, which is defective of having mitochondria DNA, with the healthy mitochondria from a donor egg. Okay, while keeping women's nuclear DNA intact. And it also allows intended parents to conceive a child with their own nuclear DNA, but with healthy mitochondria. Only the mitochondria, the defective mitochondria, is replaced from the donor to the recipient. Okay, that's why it is called as three-parent IVF. There are biological two parents, and there's one donor who is giving her mitochondria. Okay, and this is very beneficial in preventing the inheritance of lot of mitochondrial deficiencies or diseases. Okay, and the next one is IVG. It is also known as in vitro gametogenesis. So here the artificial gametes which are created, which offers a revolutionary future for fertility solutions. So something about artificial gametes. These are the future of reproduction. Okay, so artificial gametes are created through stem cell manipulation, and this breakthrough has already started at the early 2000. Okay, there's a lot of research now coming up, or there's a lot of trials now going on, but it is initiated in 2000, and this advances could help a lot of people who are having reproductive challenges, but there's a lot of ethical issues involved in such treatment. So what are artificial gametes? They are eggs and sperms generated from the other cell types, like it is from the stem cells, and the scientists, they create them through specialized cell manipulation techniques, and this field represents the intersection of reproductive medicine and stem cell research. Okay, so there are two professionals involved here, and the haploid male sperm cells can be verified through DNA content analysis, and these cells contain half the chromosome of the normal body cells. Okay, so there's current progress so far is the scientists were able to create artificial oocytes. Okay, so they are created from male cells with successful fertilization. Scientists are able to produce artificial sperms. So these are developed from female cells, resulting in live births. These studies are done among in animal models, and it has shown success. And human application is still in the research phase as of 2025. Okay, so again, there's a lot of ethical issues involved in this, because when it is applied, it can be applied to same-sex reproduction. Okay, couples could produce genetically related children, which is highly unethical. It helps in fertility preservations, like it gives a ray of hope for cancer patients, and it also integrates ART. I mean, it is a complement to gamete in vitro fertilization, zygote in vitro fertilization, and cross technologies. And also it is potential for stem cell deficiencies. Okay, so people who are lacking adult stem cells deficiency, artificial gametes holds good. Okay, and one more thing I want to share here is personalization of ovarian stimulation protocols, gamete selection, and embryo annotation. So there are various AI-driven tools which has a lot of data sets to predict what is the optimal time for ovarian stimulation, what is the quality of the ovaries, or qualities of oocyte and fertilization rate. And also it helps in quality assessment. Like, there are three things: ovarian stimulation, personalization, it helps in gamete selection, and also it helps in embryo annotations and selections. Okay, so far we have reached that with AI all these predictions are possible. Okay, but there's a lot of still debates going on about the authenticity of the use. So to conclude, a brighter future for fertility, there are a lot of breakthroughs which is happening, a lot of researches which are going on, and there's a lot of personalized treatments and new technology care approaches, and there's ethical discussions which is going on, and the future holds promising innovations to expand fertility rate. So AI is used in gamete selection, it is used in embryo selection, it is used in treatment regimen. Okay, so few of the ethical challenges which can be posed is in terms of patient-physician relationship, like informing patients is challenging because of the complexity of the algorithms. Okay, the machine learning, the ML, the NLP, all these algorithms are very different, and to inform the patient it is highly challengeable. And treatment results for individual patients are unclear, and responsibilities, transparency, and trust is still not clear. Okay, and if you consider the reproductive justice and chances of access, there's no widespread implementation, and the follow-up cost because of the complex technical operations are very high, and there is the access to specialized reproductive AI centers is minimal. Okay, so all these AI, even though it has taken up everything, there's lot of challenges, there's lot of ethical issues which is there to take up this treatment. And the pregnancy rate or the fertility rate also depends upon the type of treatment that is taken. And more than successful rates, they are becoming highly commercial. A lot of centers are making money with all these high tech technologies. So keeping in mind the innovations, I mean, the core of reproducibility should not be forgotten. Yeah, with this I conclude my topic, and thank you for the opportunity, and sorry for all the technical glitches and errors that has happened. Thank you. If there are any doubts, I'm happy to clear it.
If any doubt, please feel free to ask. You can type your questions in the chat box. Thank you, Dr. Sushmita R.K., for delivering such an enlightening presentation.
Thank you all. Thank you, ma'am, and all the organizers for facilitating this session. Thank you all.
Thank you, ma'am. We learned a lot from your session. Thank you so much.
I will leave. I will leave now.
Yes, ma'am. Yes, ma'am.
Yeah.
Thank you, ma'am.
Yeah. Thank you.
Esteemed participants, it is with great pleasure that I introduced our next speaker, Dr. Aravind R., consultant, ICRA Fertility, Kozhikode. He has completed his MBBS in 2010 from Government Medical College, Kozhikode, MS in OBG from Government Medical College, Kozhikode in 2016, DNB in OBG in 2017 from National Board of Examination, FNB in Reproductive Medicine in 2020 from Saimer Fertility Center, unit of Edapal Hospital. His accomplishments include currently invited faculty in various state and national conference, has delivered talks and involved as expert panelist in various occasions. Second best paper, All India Congress of Obstetrics and Gynecology, Agra, in 2016, Prevalence of Anemia and Quality of Antenatal Care in Pregnant Tribal Women, Attapadi. Best paper, Yuva Foxy, 2015, Maternal Near Miss Review Away Forward. Best Poster Award, Yuva Foxy, 2015, Neuroendocrine Carcinoma, Endometrium Presenting as Blindness. Paper presentation, National Conference, Fertivision, 2018, Harmful Effects of Endometriosis Surgery on Ovarian Reserve. Please join me in extending a warm welcome to Dr. Aravind R. as he shares his valuable insight with us.
Over to you, sir.
Yeah, thank you. Am I audible?
Yes, yes, sir.
Okay. Hope my screen is visible.
Yes, sir.
Okay. Thank you for that kind words of introduction. I'm extremely happy to be part of this webinar. Although it was supposed to be a live session, like due to weather conditions, we had to make it webinar. Thank you, organizations. Thank you, the nursing department of MMC for having invited me for this talk. I shall be speaking about the ethical and legal aspects of reproductive health and the public health, mostly reproductive health and reproductive rights. I was listening to the previous speaker who was elaborately discussing in depth about the innovations in the field of assisted reproduction, the newer aspects. But that was very much commendable and comprehensive. The science of assisted reproduction has been growing leaps and bounds over the last 10, 15 years, though it started its journey way back 40 years before. There's tremendous growth in technology, tremendous improvement in the success rates of fertility treatment over the last decade. But along with that, there has been a lot of ethical considerations. Commercializations have set in, and it is important that at this juncture, along with the improved science and technology, we also discussed the ethical aspects of ART. And of late, we knowing that we are all bound by law. Actually, there was a lacuna in the law aspects before, but now there's legislation in place ART techniques as well. So my topic, I should be covering mainly the legislative aspects, the ethical aspects of practicing fertility treatment in our country. So I need not elaborate because about the definition, what is infertility, such things, because there have been already 2 sessions covered on that. But to put in simple words, infertility is defined as a couple's inability to conceive naturally after 1 year of regular unprotected intercourse. But in the definition of 1 year varies from different age groups and also differing on the individual diseases or comorbid conditions they have. It could be primary or secondary infertility, like primary, like where people have not conceived at all, and secondary where they have a previous pregnancy. So, having said that, we know that infertility is a social problem. It need not be a social problem as such. In 2025, it can be a problem of the couple alone, but we have at least in our society, we have made it a social problem. It also affects the healthcare services because the money involved in these services are little big. So there is an impact on the healthcare services, and the social environment is simultaneously affected. So it is not confining to a couple's problem alone in present day practice. And it is important that I speak this topic to the nursing society because more than the doctor, the feelings expressed by the infertile couple, that is the depression, their feeling of grief, guilt, and I don't know why, but shame and inadequacy. These are best addressed by our supportive staffs who interact more in depth than the doctor. So that would be the important aspect I should be communicating with you, because these problems, these issues of psychological upset problems are to be picked up by the our supportive staffs, and has to be addressed because most people, what would they want is being non-judged, because they have a feeling that they're inadequate because they cannot conceive a child. But it is our duty as healthcare professional to convey to them that this is also just like another disease, like where there are solutions to the problems. So that is the idea how infertility has evolved as a social problem than the problem of the medical fraternity or the couple alone. So when we calculate the prevalence of infertility, it's difficult to calculate the prevalence, but the FIGO, that is the Federation of International of Gynecology and Obstetrics, they put that 10% of women are affected with infertility or subfertility globally. But very importantly, I should have a correction to this. Always don't link infertility to the problem of female. It is equally important for the male also to share the responsibility of fertility. And there is strong evidence and data to suggest that the male partner is involved in around 50% of cases having fertility issues. In around 30% of the situations, they are solely responsible for the fertility issues. And in around another 20-30 again percentage, they contribute to the fertility problems. So having said that, 50% of the cases, we have a contributing factor from the male. So it is important that we spread the message across the community and the society that infertility is a problem of the females. It is the problem of the couple. Okay. So this is very important because, as I said, it becomes a social issue, and the problem of infertility does not end with that particular couple. It is translated to the sub family, maybe the in-laws or the extended families. There are very instances of domestic violence, social isolation, increased rate of divorces happening in this group of people solely because the society's a large chunk, obviously changes are happening. A large chunk of the society feels that fertility issues are limited or it's the sole responsibility of the female partner. So that has to be primarily taken care. Now, majority of the people still do not come to see the doctor out of this 10% because of the social stigma associated with that. So many are reluctant to come to the fertility clinic. And obviously, apart from the social aspect, the cost of the treatment is considered to be a little huge. And because you were already hearing the advances that has come in the treatment, this technology has grown in leaps and bounds, but it comes with a cost. And there is unequal distribution of care, which means that qualified fertility doctors. So the a gynecologist is not always a fertility doctor. It requires additional training. I shall be coming to that. So qualified fertility doctors who address the real issues are still lacking, or are they concentrated mostly on the cities and creating an unequal distribution of care for these couples who are in need. That is why still majority do not get treatment. So is there a rising subfertility? Whether we are not very sure, but there is an increased number of patients coming to the fertility clinic. It might be due to the increased absolute number of rise of infertility or because of the increasing awareness. So, however, increasing age of marriage. So it is very important that the chemical clock and the biological clock go hand in hand. But however, that is a tough thing to do. And obviously, for a woman's reproductive right, autonomy, and independence, her career and financial stability is of utmost importance. But obviously, they're created with the disadvantage that as age increases, the fertility potential obviously decreases. So, increasing age of marriage and delayed first conception, that is staying separately from during the first years of marriage for their job or education, all these have created increase in fertility problems. Increasing sexual problems is very well evident from the patients coming to us. And obviously, the lifestyle factors like obesity, smoking, stress, use of mobile phones, Wi-Fi, hot water baths. All there are papers who coming in which says some evidence for all these lifestyle factors also contributing to rising subfertility. But however, it should be emphasized that the normal fertility rate is that 90% of couples will conceive in the first year of attempted conception. But another large chunk of people, 5 to 15%, would require another 12 months. But it is prudent that like they get evaluated after 1 year to make sure they do not have a corruptible problems. And it's also important to know the concept of cycle fecundability, which means that for a normal couple who have absolutely no issues, their chance of conceiving in 1 month is only 25%. And all treatment of infertility, all treatments have cycle fecundability rate below this 25%, except those for IVF and ICSI. So this is very important message that should be conveyed. So that is like for all other treatment, the chance for conceiving in 1 month, because like they are infertile people. I'm talking about cycle fecundability for fertile people. So it is only IVF ICSI treatment which will have success rates above this natural 25%. Okay. So this also we have mentioned in detail, that is in the previous talks also, the age and infertility, you can show the inverse relationship. As the age of woman increases, the fertility drops. And in Western literature, if you see the age decline, they mention it as 38, 39, 40. But that is for the West. For us, the Southeast Asian population, the fertility declines after age 35. Okay, there is a sharp, you can see the curve coming, very sharp, steep curve. The curve is plateau in the initial phases, but it is having a steep decline after the age 35. And the best age for a fertility or to plan a family would be between the age 20 to 30, or like if you balance, you can put it as 25 to 29, 20, 30. Okay. So this also I will be skipping because you have most elaborately discussed about the treatment aspects, which could be the IUI, the conventional IUI, which still holds its ground because of the cost effectiveness and the ease in which it can be done, and with relatively okay success rates. Then came the IVF, the in vitro fertilization. Then the newer advances in that ICSI, PGT, time lapse, stem cell, whatsoever it is, and also third party reproduction and surrogacy, in which means we are using a gamete other than that of the couple in selected cases with their consent, or it could be gestational surrogacy in which the uterus is lended uh, for carrying the embryo. We shall be discussing on. So the sphere of fertility treatment revolves around this, and in each things there are ethical aspect to be considered and legislations to be known. So in 1978, Louis Brown, this is the first test tube baby born by the work of the scientists Edwards and Streptow, who were then awarded Nobel Prize to. So Louis Brown is 40 years now, and she is with a kid she has conceived naturally. And after that, 8 million to 8 to 12 million babies were born out of IVF treatment. And India, Kanupriya Agarwal and Subhash Mukherjee, obviously there are a lot of issues associated with the Indian first test tube baby. This doctor was particularly given that credit for the first father of first test tube baby only after he had to kill himself because of the allegations that he was lying, that he was the pioneer in making the first tube. So that's all history. But as of now, this is an established technique with 8 to 10 million babies born throughout the year. So the main concerns of ART stands for assisted reproductive techniques. When we address patients, it's a success rate. So whether all the cycles would be successful? No, it's not. But the success rate has been climbing up the ladder in selected patients. It is not that we can create miracles by having 70 to 80% success rate in those at the age of 40. But those at the age of 25, for some correctable factors, we could. The cost of treatment was it was kind of not affordable for the common man in the initial years of ART, but with the technology being very common, it is now affordable. The complications are very minimal now. There were complications like OHSS in the previous era, but with advancement in the newer drugs, the complications is almost coming to a nil. And the most importantly, people are concerned about the use of other gametes during IVF ICSI, especially in our part in the rural areas. There's a lot of concern that IVF means it's the use of donor egg or sperm. That is also put to rest by repeated counseling and legislations. And the other concern is regarding the safety of the babies born out of IVF or ICSI, because these are artificial handling of oocytes outside the natural environment. But that is also put to rest because, like as I said, there are 8 to 10 million babies born, and we know studies have not shown any increase in the risk of congenital anomalies in these IVF babies. So this is an established scientific practice. Okay. So with that comes obviously when something gets established, it's a human tendency to uh, exploit it or use it in some situations where it is not supposed to be. Okay. So when you come to the monetary aspect of that, uh, there are various papers or newspaper reports, not studies, which shows at present there are about 3,000, maybe more than that, fertility clinics in India. Okay, not all of them are registered, but now the situation changed. There are a lot of couples visiting India, about 10,000 international couples visit the country to avail ART service. Medical tourism is in place. And there are about billions of money spent on this industry, maybe the drugs, the media, the machines, the instruments. So that much of money is being spent in this. And in that scenario, are we crossing the line of ethics? So a few years before this report was received in with great joy among the scientific community, that at 70 years also, man has preserved the reproductive right. But there are many people who consider this an achievement. But when you think about the legal aspects, about the right of the child born out of at this age to aged parents, or the health hazards a woman may face because she is forced to have a pregnancy at this age, if you consider those angles, we have to draw a line where this treatment can be offered or not offered. And my objective of the talk would be that to enlighten you regarding the ethical aspects. So obviously, the right to reproduction is there for everybody, but it is not an absolute right as far as the Indian law is considered, because the law is now quite clear on who can undergo ART, who cannot undergo, and what are the conditions to be fulfilled. So with that legislations in place, there will be some transparency and of these ART practices. The another thing was about gestational surrogacy, because we had many film stars, um, politicians who were opting for surrogacy for various reasons, their own private reasons or whatsoever. There were many foreigners coming to India to get surrogate mothers because they thought it would be cheap here. There were issues like once surrogate mothers deliver the baby, the babies were, there was an important landmark case in which one surrogate mother delivered a Down syndrome baby. Okay, and the couple who were like, I think, like, if I remember, they were non in like they were not citizens of India, but they were of Indian origin, but they were reluctant to take their baby because the baby had Down syndrome. So those times, these legislations were not in place. People were not aware, and there were a lot of legal battles fought for that protection of that baby. So all these things, and there are a lot of, commercialization, that the surrogate mother is not is exploited. There are in between middlemen who consume a lot of money from the IVF clinics. Such things happened, and all these ethical issues forced the government and the parliament to regulate ART practice in India with the landmark surrogacy and the ART regulation bill of 2020. So it altogether put a ban on commercial surrogacy, and then also put stringent regulations had been laid on for the functioning of ART clinics and surrogacy centers. And all the IVF clinics and the practitioners were brought under registration and timely updation of their data to the government registries. So that is the ART bill of 2021. So the objective of the regulation was not to reduce or not to curb ART practices, but to regulate and supervise the ART clinics and the ART banks. And this was to ensure safe and ethical practice of ART services and prevent their misuse, for regulation and supervision of research and development. Because the research is also something which now people are all fond of. But research has to be done following regulations, because research, you cannot again exploit another person for research. So all this was the objective of the ART bill. So the bill was passed by the Lok Sabha and the Parliament, and now it is an established law. All of the IVF clinics or ART clinics are now registered and they function according to this law. So in this, there are some definition. We need not go into the depth. We only need to understand the core concept of this bill. So what is assisted reproductive technology? Hello? Is there any problem?
No, sir.
Okay. So what is assisted reproductive technology? So all the practices in which all the techniques that attempt to obtain a pregnancy by handling the sperm or the oocyte outside the human body, okay, and transferring the gametes to the reproductive system comes under the purview of ART. Even in that, by that definition, even the IUI, because we are handling sperms outside the body, comes under the purview of ART. And what is the Assisted Reproductive Technology Bank? That is an organization which shall be responsible for collection of gametes, storage of gametes in embryo, and supply of gametes to assisted reproductive technology clinics. So they are called the bank, ART bank, which will supply the gametes. This is most relevant for third-party reproductive procedures. And what is assisted reproductive clinic? It is the premises equipped with the requisite facilities and medical practitioners registered with the National Medical Commission for carrying out the procedure. So the clinic is the hospital or the place where all these activities can be done. And commissioning couple means an infertile couple who approach an ART clinic or ART bank for obtaining the services. So these are the definitions the ART bill has put forward. And the bill has put forward the formation of these organizations. At the national level, they have the National ART and Surrogacy Board. Then there is a national registry. Registry means which collects data from all the IVF clinics or ART clinics and banks. At the state level also, there is a state ART and Surrogacy Board. And then there is an appropriate authority under the state board. Okay. So what is the function of this national board? The national board is a policy forming board. Okay. And it advises the central government on policy matters, and it altogether reviews the implementation of this act is proper or not. Okay. And it also oversees the performance of other state boards and supervise the national registry. So in nutshell, the national board has a supervisory or policy making role as far as the ART Act is concerned. And all the complaints registered from the state level are taken up to national level, and it advises the central government and the Ministry of Health and Family Affairs to bring about changes in this ART Act. And at the bottom level is the appropriate authority. Okay, so that is constituted at the bottom at the state level, and it is this appropriate authority who will grant, suspend, or cancel registration of a clinic or bank. And they will inspect the premises of the clinic and to make sure that the standards of the clinic is fulfilled. And whenever there is a complaint from the patient or any source regarding the breach of provisions of this act, the appropriate authority investigate the matter. And they have also maintenance of records, giving certificates to the commission couple, all those things about the appropriate authority. And then they recommend regarding the policy changes to the higher authorities, the state board and national board. So these are the function of appropriate authority. So example, in Kerala, if you want to start an ART center, you have to apply to the government. The appropriate authority will conduct inspections. They will make sure that the standards are met. There are qualified people, qualified instruments, They have a checklist for all those things. They will conduct inspections and then only grant a clinic registration. And only after registration, we can start the procedures. So, no person shall establish any clinic or bank for undertaking ART technology or to render this technology services unless a clinic or bank is duly registered under this act. Okay. So these are all technical aspects. We need not go into detail. That is, registration should be done within 60 days of the establishment. And when the act came, everybody had to register within 6 months. Okay, so they will conduct inspection. This was satisfactory. Physical infrastructure, manpower, diagnostic facility should be there. And when you apply for the registration, in 30 days, you have to conduct the registration, either reject or accept our application. Now, that is the function of the governmental aspect. Now, what is the function in the clinic and the bank? So that is where our role comes to it as doctors and nurses. Like, what is the role of clinics and banks? We should ensure that the commissioning couple, the woman, and donors are eligible to avail ART practices. So now comes the age cutoff for ART service. This is very important. So earlier we were telling about 70-year-old conceiving child. In my clinic, like there are people like at the age of 19, girls at the age of 19, 20, even younger than that, they come for fertility treatment. So the both extreme, it is a problem. Sometimes I also wonder, like, why at the age of 20 or 19, people want to come for an infertility treatment at the time where they have other priorities. But anyway, as per the ART law, a woman above the age of legal age of the marriage and below the age of 50 years is eligible. And there have been some amendment in which they said they have made it to be 21 and 50. Okay, at the age of 21 and 50 to be eligible for ART treatment. Okay, so above 50 years, you cannot undergo any kind of fertility treatment for a woman in India. And for the male, the legal age of marriage is 21 and below the age of 55. So why this is an important question that has been debated in courts also. There are many legislations, court cases pending that elderly couples also should not be denied their reproductive rights. But anyways, after a lot of deliberations, there will be no provision change in the provision of this age cutoff. 55 years and 50 years, that is cutoff. Why this has been fixed is because of, as I said before, a pregnancy at an advanced age is harmful, both physically, psychologically, also increased risk of anomalies in the baby. And secondly, the right of the baby, like there should be a caretaker for the baby, which is not possible in a advanced age. So this is the age bracket. And it is the duty of the clinic to follow this very confident. This is the ethical aspect of ART counseling. First thing is that you counsel regarding what is the need for this treatment for you, how much benefit you are to gain from this treatment, what is the realistic success rate, what is the real cost involved, are there any particular risk factors, and what are the alternative approaches to treatment. All this has to be very detailed to the patient, and the procedural aspects of the treatment. I mean, what are the pain they are, what are the mode of drugs, what procedures will be done. All this has to be important. So this is the right of every couple to have a counseling done. So there should be a counselor as say for the ART clinic. Okay, that is regarding the counseling part. So you all know, so in this scenario, like the role of nursing fraternity is very important because they have to approach the patient with compassion, with care. At the same time, we should convey the correct message because most people coming to us are desperate. maybe they'll come to us like after having wasted a lot of time, but still they'll be coming to us with a big hope. So we cannot deny them the treatment, but at the same time, because this involves a lot of cost and expectations, realistic expectations also be conveyed through a counselor. So that is the importance of a counseling in the ART clinic. Documentation, very important, because like what is not documented is not done. That is the dictum. So when something is not documented, we have no right to claim that it is done. So without documentations, we don't have any ground to stay. Suppose a legislation or litigation arise. So documentation is very, very important. All the aspects should be documented. Even we have a counseling register in which all the couples signed after counseling. That is, we explain the success rate, we explain the cost, and then they have a signature taken to make sure that documentation is proper. Confidentiality, very important. That is perhaps the most important reproductive right everybody has. Like the data of the couple, their confidential details should not be disclosed to anybody without their permission. Okay, so that is very important. And consent. So for all the procedures, there should be informed consent, written consent, duly signed. And especially if it is involving third-party reproduction, the counseling has to be extensive, and the consent of both the partners is very important before embarking on any treatment. So these are the duties of the banks. So as per the amendment acts in the amendment, there are different levels of ART clinic. Level 1 clinic is the where you do the IUI procedure. In level 2 clinic, the ICSI IVF treatments are done in the level 2 clinic. And level 1 clinic, there should be a gynecologist alone. At clinics, there should be a counselor, a gynecologist with fertility qualifications. They have laid down qualification for that. A clinical embryologist and anesthesia should be there in level 2 clinics. Okay. So this I'm not going to detail the qualification of gynecologist. He should be gynecologist with experience in fertility, or he or she should have additional super specialization like DM or fellowship in reproductive medicine with 3 years of working in ART clinic. And these are the qualifications for other personnels. Okay. Now, when you come to third-party reproduction, there are strict regulations regarding the donors. So a donor cannot donate sperm or egg n number of times. It should be only once. So earlier, this practice was not very strict. Obviously, this is a very hazardous thing. A person donating semen multiple times in the same community, it's going to be very deleterious effect. So there is regulations that only once in a lifetime, males between age 21 to 55 years of age can donate sperms. And once in a lifetime for females between 23 to 35 years can donate eggs. With after examining the donors for any such diseases as prescribed. So this is important. And as far as who said donors are concerned, there should be insurance in their name. There should be compensation in case of untoward incidents, because it is a surgical technique in which patient is given anesthesia and the eggs are taken. So there should be an insurance coverage for that donor, and that is also the responsibility of the ART bank. Okay. So the oocyte donor should be a married woman with at least one living child of her own with minimum age of 3 years and can donate oocyte only in once in their lifetime. Okay. And we can only collect 7 eggs from an oocyte at a time. This is also put because like there was a tendency to exploit these oocyte donors by giving high dose of injection and get maximum eggs. But that will create complications like OHSS. So we have to protect the right of that woman also who is donating eggs. That is where the law is clear that only 7 eggs should be collected from the oocyte donor. Okay. So regarding the sperm donor also, the name, identity, address, all things has to be documented and maintained, but it should be confidential. Okay. To most importantly, rights of the child born through ART, whether it is self-parentage or if it is third-party reproduction. It is important that law clearly lays the child born through ART technology should be deemed to be a biological child of the commissioning couple and shall be entitled all rights and privileges available to a natural child under any law for the time being in force. So that is very clear and crystal clear on the rights of the child. And if it is involving a donor should relinquish all parental rights over the child or children which may be born from his or gametes. Donor has no right for that child. And the law also regulated when there is offenses committed in the field of ART. It could be abandonment of the child born through ART. It is a serious offense. It could be exploitation of the gamete donor, the commissioning couple by the clinics or any woman, or sometimes even the sale of embryos, import gametes from outside India. All these are serious offenses. And sex selection, we know that PCPNDT Act is in place. So all these are the offenses considered under the Act, and penalty is first time it's a fine up to 10 lakhs, and second time this is not that it is imprisonment for 3 to 8 years for all those involved in this act, which includes the medical, all the healthcare workers who are involved in this treatment. For these any of these offenses, there should be there is a provision for imprisonment up to 8 years. So that strict is the new ART Regulation Act. Now, when you come to the Surrogacy Act, so these are two separate bills which was passed by the Parliament. What is surrogacy? So, surrogacy practice whereby one woman give birth to a child for an intending couple with the intention of handing over such a child to the intending couple after the birth. So that is surrogacy. So traditionally, surrogacy was of different types. There was gestation surrogacy, which was of again two types, that is altruistic and commercial. Altruistic means it was not involving money. For example, suppose a female cannot bear a child due to various medical indications. I'm not detailing to the medical indications now. Then her sister becomes her surrogate, or the mother becomes surrogate. Okay, that is purely altruistic. Okay, without any money movement. Then there's commercial surrogacy, in which when a couple is unable to bear a child because the uterus is weak or whatever indications, they're opting for surrogate for medical indications. Okay, it is now only for medical indication. You cannot just opt surrogacy because you can't bear a child. In that case, somebody unrelated to them agrees to bear the child by getting a compensation, monetary compensation. It is called as commercial surrogacy. So these are in practice for long. You all must have seen the famous Malayalam movie Dasharatham, which way back introduced the concept of surrogacy, and you must have seen the emotional and the psychological aspects of that surrogate mother as well as the couple, not the couple there, but the parent. Okay. Having said that, like I should make clear that surrogacy for single males are not allowed for in India at present. Okay, so these are different types of surrogacy. So the medical indications are mainly for uterine anomalies, like when there's absent uterus, the girl is not menstruating because of the syndromes like MRKH, or surgically removed uterus because of cancer or fibroid, or recurrent pregnancy loss, recurrent abortions. All these are common very broadly, these are the indications in which a surrogacy can be done, or some serious disorders from the female partner which prevents them from carrying a pregnancy. So now surrogacy is allowed only made for medical reasons. Earlier, I was showing the pictures of many film stars who had children born out of surrogacy. That is not allowed now after the law has come. So that is the need for legislation, because like there were a lot of exploitation for the woman happening. Okay. So that is the Surrogacy Act also came to a place in December 2020. And the Salem features it bans commercial surrogacy altogether. Okay, so there's a complete ban on commercial surrogacy. No money involvement is possible for surrogacy in India. Obviously, that is a double-edged sword, because when there's complete blanket ban, there is a tendency that surrogacy may come to an end altogether. But obviously, the law is states so as of now only allows altruistic surrogacy. And in what is altruistic surrogacy? In which no charges, expenses, fee, remuneration, or monetary incentives of whatever nature, except the medical expenses incurred on surrogate mother and the insurance coverage on surrogate mother. So only the insurance coverage and medical expenses the surrogate mother can take. Other forms of surrogacy is not allowed. So there's a lot of debate on this, because many people said that for some people surrogacy was a means of livelihood, especially in northern part of Gujarat, Maharashtra, which are considered surrogate capitals. So there were a lot of women who could clear their debts, who could get a good livelihood because they are adopted commercial surrogacy. But obviously, our lawmakers had elaborate discussions. They had not only doctors were involved in making this law, social reformers, women activists, everybody was involved. And finally, they had concluded that we should be putting a blanket ban on commercial surrogacy. So gestational surrogacy at present it can be done only for altruistic purpose, not for commercialization, and not for producing children for sale or prostitution or in any form of exploitation. We must not have thought about all these aspects, producing children for sale, creating an embryo and creating a girl child for sale. So, but obviously it must have happened somewhere. That is why that clause is also there. And only for some and only conditions, yeah, medically indicated surrogacy is now possible. So who is eligible for surrogacy? Indian infertile couple, very important. Legally married Indian man and woman aged 21 and more than 18 years respectively, have a medical indication necessitating gestational surrogacy. And for surrogacy as such, the age should be 23 to 50 and 26 to 55 for the man. So it is legally Indian married men are married couple. And they do, if they do, they should not have any child previously, except if there is a physically or mentally child who or suffering from life-threatening disease. That is also a controversial clause, because like once they have a normal child, they are no longer permitted to have a surrogacy later. Widowed women are permitted to have gestational surrogacy from a donor, from their partner, or from a sperm donor, age of 35 and 40 years. Divorced women are also eligible between age of 35. Indian origin couples with age criteria or overseas card holders or parents of Indian origin are allowed. Okay, so who are not allowed? Single, widower, or divorced men are not allowed to have a child by surrogacy. Single, unmarried women are not allowed. Divorcees or widowed women are allowed. Couple in living relationships are not allowed. LGBTQ intending parents, again, a very, very controversial topic. There was court cases and rulings by Supreme Court on gay marriages, but it's not permitted now. Again, they do not have the right for surrogacy as of now in India. By LGBTQ, I mean there are, but obviously I should tell you that there are cases where surrogacy has been done in those who have gender reassigned. Okay, that is an important thing. For example, like the trans men or women, when they have reassigned a gender to woman or man, and they are eligible for marriage. Okay, and there are a few couples even in Kerala, like they are eligible to for marriage in India. Such people can undergo surrogacy also. There are cases where it is done in Kerala also. Foreign couples, that is foreign citizens, like foreign couples, that is non-OCI and non-PIO. So there are many foreign citizens who are of Indian origin and Indian card holders. They can avail surrogacy, but completely foreign couple cannot come to India for getting a surrogate from our country. So these are the strict regulations regarding surrogacy. Who can be surrogate mother? That surrogate mother lady should be ever married woman, ever married. She can be a divorcee or widow also, aged at 25 to 35 years, and has a child of her own, and she should be a willing woman. And she cannot give her own gametes. That is, she cannot, the surrogate cannot donate egg. Surrogate can only be a carrier. That is, she can only lend the uterus. Only once in a lifetime, she can undergo become a surrogate mother. So all this requires a certificate of approval from the said national board and the national registry, and eligibility certificates is must, and only then we can have this surrogacy done. And very importantly, the rights of surrogate mother and child. So the mother has the right to withdraw from the procedure any time before the embryos are implanted. Okay, and very importantly, she has the right to consent for can to ask for a medical termination of pregnancy if it is indicated. So MTP Act has strict indications for medical termination of pregnancy. The same applies to the surrogate mother also. It is not that because she's a surrogate, she's bound to carry that. For any indications for her mental, physical, or the child's problems, there is a provision for MTP, which the surrogate mother also has the right. And the child born of surrogacy is deemed to be the biological child of the couple, of the commissioning couple, and is entitled for all rights and privileges available to a natural child under any law for time being. And that is the responsibility of the couple also. Suppose the child born of surrogacy is having any anomalies or any genetic problems, the couple cannot abandon the child. The law strictly prohibits abandonment of the child in India or outside for any reason whatsoever, including but not limited to any genetic or birth defect or any condition, the same developing subsequently or based on the sex of the child, of conception of more than baby, or any of these reasons, abandoning the child is a offense. So these are through these regulations in place, I would say that the ART Act has got the transparently which we always wanted for. Because a lot of ethical aspects after due deliberation. This, if you look at the history of this ART Act, way back in 2010, this discussions regarding the ethical aspects of ART has begun. But in those times, there were only guidelines from the ICMR. So what's the difference between guideline and the law is that guidelines are like, okay, this is good to do this, that's all. You cannot get punished for not following the guideline. Guidelines are not mandatory. That is just for our reference. So these guidelines were there in place for long. But then because of this increasing complaints, increasing exploitation of the oocyte donors, surrogates. Also, the couple, the parliament or the lawmakers were have done the right thing by deliberating with the doctors, social reformists, women activists to bring on this AIT legislations. So it is important that the strict adherence to these legislations. That is the most important aspect of reproductive right and autonomy of the woman. And also, before I conclude, I should mention another point about egg freezing. Because I will be speaking, I was also assigned to speak about reproductive right. So perhaps egg freezing is one of the important thing which is a matter of woman empowerment. That technology has helped a woman for their reproductive autonomy because they can freeze their reproductive potential As I said, the career clock or the biological clock are always not ticking together. They always tickle in the opposite direction. So uh, this technology has, by social egg freezing, has permitted women to uh, to delay the childbearing, but without affecting the chances of childbearing at a advanced age. That is a big thing that has come. The egg freezing is also then another thing is about oncofertility. So the reproductive rights does not start only after 18 or 21. It starts for the children as well. For men and women, earlier there were many cases like in which those undergoing fertility treatment, whether it be surgery, sometimes the ovaries are removed at 12, 15 years of age, but nobody cared the right of that child to reproduce in future. Sometimes testicles of children were removed for cancer at the age of 12, 14. But that some time back, nobody cared about the reproductive right of that particular boy 10 years later. But things have changed. There is the area of specialization called oncofertility, in which the fertility specialist and the oncology team work hand in hand, and any sort of gonadotoxic treatment at any age. So there is a fertility preservation option. It could be sometimes egg freezing, it could be semen freezing, or previously discussed sometimes oocyte tissue preservation. It's like little difficult task, but all this is that. The concept is that we have to technology is in place, but a mindset are not still in place in many cases. That is the importance of realization which all the medical fraternity should have. If you have a will, there'll be some, there's a way, but we have the way. But as somebody practicing in fertility medicine, I would say that the mindsets are not yet ready, completely ready. Obviously, there's a change happening for all these things. So, reproductive right is an important right at whatever age it is concerned. And most importantly, reproductive right does not mean right to have a child. It is also the right not to have a child. Very, very important. Because like a big chunk of people who come to our clinics, they are not motivated to have children, but they are forced to come because of the pressure from their family, friends, or the social conditioning that okay, we are somehow we need a child because society wants it, even though we personally do not want. It is the norm of the society. So reproductive right also implies the right of a particular couple not to have children also. So that is a broader aspect of all this. So I hope with my talk on the legal aspects are technical, but most importantly, my area, I am very happy I got to speak this topic, not the advances in fertility, because advances like that is a technical aspect. But this part has to go deep into everybody's mind and heart, so that we are aware of the correct ethics of reproduction, reproductive right of women particularly, as well as the men also. I would not uh, disregard any of this. So that is the message which I would like to give. The take-home messages would be ART is a very established and safe, effective fertility treatment with reasonable good success rate, and the couple shall go for ART at the right time, not the last resort. That's very important. There should be strict adherence to legislations, and the latest evidence put to rest the concerns regarding the long-term outcome of babies born after ART. And very importantly, the ethical and legal issues, the matters of commercialization should be addressed, because we are ethical practitioners. We have to do justice to ourselves, to our mind. Reproductive autonomy of the couple, that is the word which is to be highlighted. Reproductive autonomy of the couple should be respected throughout, whatever be their decision. So these are the concluding remarks. Thank you once again for the organizers for this wonderful webinar. Hope you had a good time. Thank you.
Dear participants, if you have any doubt, please feel free. You can type in the chat box and we'll be addressing it. Sir, there is one question.
Yes, yes.
What are the ethical considerations regarding against sperm donation?
Yeah, that's what I said. Sperm donation is permitted in India. For those, but it should be, first of all, consent of the couple, that is, who are receiving the sperms. Both female and male partners' consent should be there. That is the most important thing. Then, regarding the sperm donor, there is an age criteria for the sperm donor. He can donate sperm only once for a lifetime, not many, many times. And he should be asked some questions regarding this history of some diseases, and necessary investigation should be done. So these are the ethics of sperm donation.
Thank you, sir.
Thank you, Dr. Aravind R, for delivering such an enlightening presentation. We are incredibly grateful for the valuable knowledge you have shared with us. Thank you, sir.
Thank you very much. Thank you very much.
Kindly take a few moments to jot down, share your feedback and insights. Your honest input will be instrumental in shaping the future editions of this webinar and enhancing the experience of all participants. I remind completing feedback form is required in order to receive certifications. Once again, I request
Hello.
Yes, Vrinda.
Hello, ma'am.
Yes, Vrinda, you are audible.
Okay, hello, ma'am. At first, I thank you for arranging this valuable session. Actually, it was really informative to us, especially the second session, ma'am. And I learned so many new things, and also it helps to update my knowledge on the reproductive health topic. And also, along with, again, I thank you all, ma'am. Thank you so much.
Thank you, Vrinda, for your feedback. Now, as we come towards the end of this insightful and enriching session, it's time to express our gratitude. Now, I call Ms. Rubia Kea, Assistant Professor, Department of Obstetrics and Gynecologic Nursing, Sree Anjaneya College of Nursing, to deliver a vote of thanks.
Good afternoon, everyone. On behalf of Sree Anjaneya College of Nursing, I would like to extend my heartfelt gratitude to each and every one of you for joining us for this insightful and engaging webinar. First and foremost, I extend our heartfelt thanks to our chairman, Mr. V. Anil Kumar, and Dr. Sudha Anil for their selfless support and inspiration throughout this event. I want to express our sincere appreciation to our eminent speakers. Dr. Professor Savita Nayak, Vice Principal, Nitya Usha Institute of Nursing Science, Mangalore. Dr. Sushmita R.K., Associate Professor, Manipal College of Nursing, Manipal Academy of Higher Education. Dr. Aravind R., Consultant in Reproductive Medicine, ICRA Fertility, Unit of ICRA Hospital, Kozhikode.
for sharing your expertise, knowledge, and valuable insight with us. Your contributions have truly enriched this webinar and provided our audience with invaluable information. Our heartfelt thanks got out to our honored principal, Dr. Professor Jorli Jod, whose unwearying support, meticulous planning, and executions have played a significant role in the smooth running of this webinar. Next, I would like to express sincere thanks to our beloved Vice Principal, Dr. Professor Regati, for her immense support and guidance. A special thanks to all participants for your active participation, thoughtful questions, and contributions to the questions. Your engagement has made this webinar a dynamic and interactive experience for everyone involved. Then, I would like to express the sincere thanks to our IT department of Malabar Medical College Hospital and Research Center for their technical support and throughout the webinar. I would like to acknowledge the hard work and dedications of the organization team behind the scene. Mrs. Jinsi PM, Mrs. Rubia Kaya, Ms. Archana A, Mrs. Anjuraj, Ms. Anupallavi, Mrs. Arjuna KK, and Mrs. Anupriya, Department of Obstetrics and Gynecological Nursing, Sree Anjaneya College of Nursing. I am very much thankful to all my colleagues and staff members who always stand by us and motivate us. I feel proud and thank you for making this event a successful one. As we conclude this webinar, let us carry forward the knowledge and insight gained today into our respective endeavor and continue to strive for excellence in our field. Thank you once again to everyone involved and look forward to your continued support in your future endeavor. Have a wonderful day.
Kindly take a few moments to jot down and share your feedback and insights. Feedback link will be shared in your registered email IDs. I remind you all, feedback form is necessary for getting certificates. With that, we come to the end of today's webinar. We hope you found the session informative and useful. Thank you for being with us today. Stay safe, stay inspired, and we look forward to seeing you in our future sessions. Once again, thank you all for your active participation and engagement. Thank you.